And with that, I'm pleased to introduce our next session. So precision oncology is largely dependent on laboratory-based biomarker testing. However, the evolving landscape of advanced biomarker testing reveals obvious gaps across and within jurisdictions with respect to turnaround time, quality standards, and reporting of the results. The questions yet remain. Is a national framework to standardize the process advisable? And what is needed to make improvements to the system which will benefit cancer patients? This session was inspired by one of the calls to action from last year's conference, and we're really excited to delve in a little further to better elucidate what is really needed to move the needle here. For this panel discussion, we are quite pleased to welcome Dr. Shantanu Banerji, Director of Precision Oncology and Advanced Therapeutics at CancerCare Manitoba, who will be moderating this session. We also welcome Robby Spring, breast cancer survivor and patient advocate, Dr. Doha Itani, Division Head of Molecular Diagnostics and Cytogenetics at St. John Regional Hospital, Dr. Jason Karamchandani, President of the Canadian Association of Pathologists, Dr. Angela Hyde, Medical Oncologist and Medical Director of Clinical Services at the Center for Translational Genomics in Newfoundland Health Services, and Dr. Janessa Laskin, Medical Oncologist and Clinical Researcher at B.Sc Cancer. Welcome to all of our experts. And Dr. Banerji, I'll pass it over to you.
Thank you, Cassandra, and good morning to everyone. Apologies in advance. I'm just getting over some laryngitis, so my voice is not normal today. Welcome to the panel, and thank you for the opportunity to participate today. So as Cassandra introduced, the laboratory plays a very important role in implementation of molecular testing, and especially on the road to CGP. So perhaps I'll start with Dr. Itani and ask, from a laboratory perspective, what is the current landscape of testing in your area, and what do you see some of the major challenges at present?
So currently, we do face a lot of obstacles in developing and implementing new tests. However, I would say that we were lucky such that we have such a limited workforce that pushed us into implementing comprehensive genomic profiling. I did not have enough people to batch different tumor types, lung cancer, colon cancer, melanoma, and be able to run the test in an appropriate turnaround time where the patient can benefit from the results. So basically what we did is we joined all of those panels in a much, much larger panel. We didn't personally join them. We looked for a panel that's available. That's another thing. We did not have the manpower to actually develop our own panel. So there's always limitations, especially in human resources. And by using that large panel that was available commercially, the validation was relatively easy. And now my technologists who were having to deal with multiple protocols for each tumor type are dealing with one protocol. They can keep their proficiency in place. And we were able to drop our turnaround time within the lab from 40 days to 12-ish days. We are now reporting within the lab for 12 days, approximately, like that's the average, right? Some cases are more complex and require more work. Some cases need repeating, but those are the fewer cases in the lab. And by using that approach, which happened to work for us, it was a little bit more expensive. So that was another fight we had to go with. We had to bring in research grants, clinical support validation grants. We had to phase out a bunch of our less used tests. And currently for those less used tests, I'm using the CPG panel, which is much more expensive for that one particular target that we're looking for. But because of the lower number of cases in the lab that require those particular targets, we end up at the end of the year having, our budget is within the required. So we happen to have a throughput that allows us to implement comprehensive genomic profiling. I would like to say if we grew too much, I don't know if we'd be able to maintain comprehensive genomic profiling. So if you're too small, if you're too large in terms of patient population and the amount of cases, that might be disruptive to adopting that. Or the alternative is you will need more funding and more human resources and more, to maintain it and so on and so forth. So that's the landscape in terms of solid tumors in New Brunswick and specifically in Horizon Health. So that's my background for now.
Great, thank you. I guess Dr. Laskin, I'll jump to the other coast right now and sort of ask you the same question, which is what's the current landscape in British Columbia, and what do you see some of the main obstacles for you right now?
Yeah, thanks, and good morning, everybody. So just a reminder, I'm a medical oncologist. I don't run a lab or have that kind of expertise. But in British Columbia, we do have really kind of two main platforms. There's the clinical testing standardized panel that's gone through a few changes over the years. We did have an in-house one that's mostly been replaced by a commercial panel. And the same idea is that all tumor types, pretty much all tumor types, go through one panel that I, as a lung cancer oncologist, I'm mostly interested in part of the panel, but the people doing GI would be interested in a different part, but we all get all of the results. And I do appreciate seeing all of them, even if some of them are less relevant. The testing is centralized in Vancouver, so I know there's some issues sometimes with turnaround time, mostly not in our lab, but with trying to get the tissue sent. Sometimes even from across the street seems to take just as long as from across the province. And I think those are issues that are difficult to solve because they can be different based on each city, each hospital, and so on. And then, I think that has helped us a lot in terms of accessing treatment for patients across the province, and we try as much as possible to be equitable with that testing. Although, of course, if the test takes longer from a more remote community, then people are less likely to benefit from those results. And then I wear another hat, probably for this panel might be more appropriate, is that I run the clinical aspect of a large prospective cancer research program, for which we do whole genome transcriptome sequencing across all tumor types across the province. And I think that the role is really for that program to push the edge, push the envelope, see how much information is really necessary, and the kind of education that my colleagues, as well as patients and advocates, require across the province and across the country to prepare themselves and prepare ourselves for pushing the envelope of what kind of genomic information we want and how we need it, and what will that mean in terms of access, innovative treatments, repurposed drugs, and expand our ability to treat people based on their individual cancer characteristics. So there are a lot of gaps, but I also know that we've improved a lot in the last 20 years, and I look forward to pushing that as we move forward.
Great, thank you. So you've got sort of very functional clinical panels that are being widely used, and you've got this sort of comprehensive research program. Where do you see comprehensive clinical testing fitting in between those areas?
Well, I mean, I'm pretty biased. I feel like this kind of testing is information, And I don't feel like information is ever a bad thing to have, whether you can use it or not. And information that I couldn't use 5 years ago because there wasn't a drug then becomes useful. So I am very much in favor of having as much information as possible. And whether we actually need it at that moment is only in some ways a secondary endpoint, because as we understand more about our population on a broader spectrum, I think that that's helpful. Of course, there are gaps. Tissue is a big problem. We can't always get tissue. Different qualities of tissue. So fresh tissue is really good for comprehensive, for RNA sequencing in particular. That's not always easy. I think there's a big role to be played for liquid biopsies and ctDNA, and that's not really reimbursed in British Columbia, only in a few instances. So I think that we need to have some flexibility to be a little bit more creative and efficient in our use of some of these testing platforms, because we're not trying to waste money and test unnecessarily. We just want more information. So, gradually these gaps are trying to be addressed. But it remains an issue for sure. And then most people only get one test at one point in time. And we know, of course, that's when you have a metastatic cancer that's being treated, cancers evolve over time. And we need the ability to be able to test sequentially to really ideally understand what cancer somebody is dealing with at any given moment. So that's my bias. I am biased.
As we all are, but thank you. Thanks for that. So we'll hop coast again back to Dr. Hyde in Newfoundland. And again, similar question to you. What is the landscape of testing currently in Newfoundland, and what do you see some of the challenges you face?
Thank you. So the current landscape in Newfoundland is that we are not currently offering we're not currently performing any of the testing in-house. We're gearing up to, but right now everything we are sending out. And so really it is sort of tumor site dependent and dependent on the external lab that we have arrangements with in terms of what we get back and what the reporting structure is. So we have a long ways to go, but we are making efforts. So we do have an NGS lab that is up and running. We're validating our germline protocols now. We'll be offering our germline testing in-house by the end of the summer. And the next step would be hematologic malignancies and then solid tumors. Solid tumors were sort of intentionally delayed, although that was, one of my priorities, of course, as a medical oncologist, but just simply because there are a number of process factors that need to be addressed within the lab medicine program, pathology, to help to support providing the tissue, scoring, this is the area that's tumor, the percent tumor cellularity, and that sort of thing before we can really go live with somatic testing in-house. So right now, everything, like I said, is sent out. So the challenges have been those systematic changes that we need to make in-house, getting the right people on board to recognize the need for change and moving things forward. And I think we've made great progress in that over the last couple of years. So we are, like I said, making strides. We're going to be going live soon with germline. And one of our other, I guess I will say, barriers that we've had in terms of when we do choose an external lab and, for our biomarker testing, there has been some hesitancy, sort of the opposite of what Dr. Laskin has just mentioned in terms of the more information, the better. We're seeing a hesitancy because this is still fairly new. We have not had the POG program. This is, kind of new for us, that too much information is, am I medically legally responsible for having all of this on the chart? I want the information that I can act on. I don't want to be responsible for all of the other information that's going to come back to me that's got my name on it in the chart. If you order it, you're responsible for it. 5 years down the road, if this variant of unknown significance becomes relevant, is it my responsibility to go back and see that? Who's got the responsibility? So sort of navigating that has been another challenge that we've been facing on this side.
Thank you. So you've gone through a lot of changes and at least growth in this area over the last few years. How how easy has it been to come around by the funding, and what are your sources of funding from this, and where do you think the ministry or the overarching health authority, what role are they playing, and what do you think the uptake is on this trend at the ministerial levels?
So we've been lucky. We've been working with some of the executive of our provincial health authority, and it is one provincial health authority, which gives us an advantage that way as well. And at the executive level, they've been supporting us. And we had a recent, within the last couple of years, a health accord was written. Really looking at what is the status of healthcare in Newfoundland and what are the changes needed moving forward. And having a comprehensive translational genomics program was included in the calls to action by the health accord. So one of the authors of the health accord then had a role as an assistant deputy minister within the provincial government department of health, and so was quite supportive on that end, helping us to get funding to get a new program, a Center for Translational Genomics, up and running. And so that's been the big change, is getting the support at the executive level within the health authority and at the government level to help really drive this. And so it's a multi-year, multi-phase program as we're trying to get the human resources and funding to stepwise implement the changes needed.
Thank you. So Dr. Kamchandani, you're at McGill. What do you find is your access to laboratory-based testing right now, and some of the challenges and opportunities going forward?
Thank you, Dr. Banerji. I think this is an incredibly timely time to have this discussion. It combines two of the most critical priorities in lab medicine in Canada. The first is, I assure you that all of my colleagues, when they go to work, they want to provide the best care possible. And currently, there are inequities in access to advanced testing in different provinces. It varies not only by province, it varies within a province based on tumor site. And in a concrete example from my province here in Quebec, I am able to order different tests for my pediatric patients than I can for my adult patients, even if they both have brain tumors. So we're dealing with a heavily fragmented system, and the approval processes are different in different provinces. We've already heard a reference to the need for working around liquid biopsy because accessing tissue is challenging. There's not even a reimbursement code for liquid biopsies across the province, and where they do exist, they're often tied to a single cancer site. So we really do have some challenges on the fragmentation side. As I mentioned, this is so important. We held a national conference on this in Montreal in May. The two things that emerged were certainly that there is this problem with fragmentation, and there's really there's not even clear guidelines on how to make progress within an individual province. So as an example, in CancerCare Ontario, an approval of a drug is not necessarily tied to the approval of the funding for the appropriate companion diagnostic. That's different here in Quebec, where at least the two go hand in hand, but we also duplicate some of the work that's being done by the Canadian Drug Agency at a provincial level. All of this in the backdrop of what Dr. Itani said, which is the most critical crisis in lab medicine in Canada, which is a pan-laboratory shortage in personnel. Now, a few years ago, that extended merely to the lab technologists, the MLAs, MLTs. That has extended through the lab right up to the level of medical pathologists. And so in a background of a human resources crisis, we struggle to figure out how to even address this critical need that will allow us to provide this essential care to Canadian patients.
And thank you for that. And I think that's a challenge we're seeing coast to coast. What are some measures that you're taking or your jurisdiction is taking to potentially address the human resource aspect of things?
That's another excellent question. Now, I really love Dr. Itani's point about how they reconfigured their workflow to respond to a challenge. And ultimately, that produced an improvement in care. The concern now is, can you keep that sustainable? So in Quebec, at least on the advanced diagnostics side, a group was formed, the Réseau des données moléculaires du Québec, and they are organized to at least think about this proactively, but we still exist in a reactive way. And so as one example, in the last month of my practice, I'm aware of a patient with breast cancer who carries an estrogen receptor mutation. If we follow current guidelines, that patient would have to fail therapy before that patient would have access to the testing to discover that mutation that made the first round of treatment ineffective. We have to change our philosophy from constantly reacting to new information to thinking how we can do this proactively, but also responsibly. Dr. Hyde's point about being responsible for the data produced by tests is an incredibly important one. So not only do we produce enormous amounts of data, I believe we should be trying to produce even more, but communicating that data is a challenge. My RNA sequencing reports are 6 pages long. So my poor clinical colleagues, already stretched for time, already trying to provide complex care in an evolving field, have to wade through pages of text to try to extract the meaningful information. That doesn't seem fair. So we have twin data challenges: how to generate more data and how to communicate that data effectively, how to store it responsibly so that when that data becomes usable, we can retransmit that in a way that protects our clinical colleagues from confusion and hurt feelings years down the road. It's a really interesting problem, but it's a problem that I think should be solvable. And concretely, to answer your specific question, we have a proposal here in Quebec. We believe that we should be doing comprehensive genetic profiling for the first diagnosis for all cancer patients, and we follow up those patients with liquid biopsies to try to understand why these patients aren't responding in a typical manner.
Great, thank you. I'll move to Robby Spring. Robby, you've been intimately involved in sort of the landscape of biomarker testing, companion testing, and the evolving environment for many years now. You've heard the various progress but challenges in jurisdictions across the country. From your perspective, what are some of the key elements that stand out to you with respect to the laboratory opportunities and challenges?
Yes, thank you. And thank you for having me here. So from the patient perspective, because that's what I could provide best, the challenges are time to access these tests, the wait time and the length of time, and then also the when and how these tests are ordered and utilized. And so I can give the example of my family. So within 5 years, 4 out of 5 of us had cancer. My mom had breast cancer in 2019. My sister and I had breast cancer at the same time in 2023. And our dad was diagnosed with prostate cancer at sort of the end of 2023. We knew he had it, but really diagnosed and treated last summer in 2024. And so my mom never had access. She had access to, the typical breast cancer biomarkers, but she didn't have access to any comprehensive genomic profiling, which is quite important in breast cancer. We didn't know anything about cancer at the time, so our assumption was hers was not aggressive. We didn't have a genetic history in the family, and no genetic abnormalities came up, so we moved on from that. When my sister and I were diagnosed, she was stage 2, so she didn't get access. She had her biomarkers tested. She didn't get access to any comprehensive genomic profiling, and she was automatically funneled into like a standard treatment pathway. When I was diagnosed at the same time, our treatment, even though our biomarkers were the same, because I was stage 1, I had to wait like 11 weeks from the time I was diagnosed to the time I was treated, which was way too long, to not receive. Then I got comprehensive genomic profiling done, or MammaPrint, in 4 months after I was diagnosed. So after my surgery, I had a couple of back-to-back surgeries to find out that I had a highly aggressive subtype of breast cancer and required chemotherapy. There's some evidence to show that having luminal B breast cancer requires, actually, even if you're stage 1, upfront treatment. And so, that how and when is really interesting, because I was the first out of the 3 of us to actually get this type of testing to find out that we did have an aggressive, presumably, because we don't know what my mom and my sister actually had, presumably an aggressive subtype. And so this process led me to push for my father to get comprehensive genomic profiling done on his prostate cancer. His surgeon agreed to it after he had his surgery, and he was told it would take 3 or 4 months to get the results. He waits 3 or 4 months, calls to ask, finds out that there was some sort of error with the sample. It was never done. It was never ordered. The sample was lost. Then they said, we'll reorder it, but it's going to take another 3 or 4 months. So 8 months later, he finds out that either there was some issue with the sample again, or whatever it was, they couldn't do it. There was no more sample left. And so he never is going to be able to understand the full relevance of the prostate cancer that he was dealing with. And for most men, and for dealing with prostate cancer on the surface level, it's so common. It's like you're being told, oh, it's fine, it's early, it's highly treatable. But having now gone through, this kind of crazy trajectory with like his 2 daughters and his wife having had breast cancer, and knowing like now me diving into this space and knowing that cancer treatment and the way that cancers grow and the way that they mutate is highly variable based on the person and where it grows and whatnot. It's unsettling from that patient perspective. So we're talking about now inconsistencies. We're talking about a privileged family with knowledge, access, and then receiving highly different treatment advice. And yeah, this lab error. So from the patient perspective, it's concerning because I now, immerse myself in the breast cancer community. And of course, I'm doing the work as a patient partner in the biomarker space. And you're seeing it's the Wild West in the country. It's highly variable from province to province. It's actually very variable based on who is your oncologist, what hospital you're being treated at, which will dictate what you have access to. Then for breast cancer patients, your samples are actually sent to California, so we don't even have access to MammaPrint and Oncotype, and granted, they're private companies. So of course, for those specific tests, but like at some point, it would be nice if we actually had like national capacity. And so when we talk about these tests, we have a system that is completely not prepared, not ready to actually like conduct these tests, to do it consistently, and to give patients reassurance that they're actually being taken care of in the system. So I don't know if that answered your question, but
No, that's great. I think so. First of all, thank you for sharing your family's journey. I think that while every journey is unique, I think you've highlighted a lot of the complexity, which is as you said, the inequality and the variability that exists within centers, and I think hopefully we appreciate through the conversations this morning that there's significant variability across the country. So I think we collectively as people who care about this field, we've been advocating for a national framework for some time, and I know several people on the webinar today, including yourself, are involved in these national efforts. So what do you see as sort of the role of these national efforts and the potential of this process?
Yeah, from the patient perspective, and obviously, sitting and doing the work of it, I think it would be amazing to actually have a national framework. It would help other patients as well, looking for more information and to understand whether their biomarker should be tested, like to know if it's already been approved, what's happening on that front. Talking about companion diagnostics and therapeutics and pairing them together, having consistency is essential as well. So a national framework would allow that, but it's really just having equitable access to biomarker testing across the country. And so having a national framework and guidelines will set some sort of standard, so it is not so piecemeal and different based on province, hospital, oncologist, of what's being ordered. It really is essential. And so this is a first step, I truly believe, in the right direction for being able to have a system that's ready to have comprehensive genomic profiling. It is something that is going to be piecemeal, and I do believe that it will take some time to actually get those pieces in place, but I think it is like essential and a right step to where we need to go.
Great. So just if I didn't mention it, there is a CDA process, or the Canadian Drug Agency, that's trying to put a framework together. For those who were on the webinar yesterday, Dr. Laura Weeks, representing the CDA, provided some background on it. So thanks for that, Robby. I was going to gauge sort of the impression of others on the national framework as well. But before I do that, Cassandra forwarded a question, an audience question, which I think now is a good time to perhaps pause to address. So the question's for Dr. Hyde. Yesterday, Don Husserl presented the state of readiness report, or at least the preliminary findings. And Newfoundland actually received the highest score. I think you got an A. I'm not sure if you saw that yourself, but Newfoundland got an A, which was the only province to get an A, which was the top mark for readiness for genomic testing. What is your reaction to that revelation?
Thank you. That's a good question, and one I was actually sort of anticipating, because I was surprised by the A score until he got into really explaining what we're scoring and what he was looking at. For Newfoundland to come across as at the top of anything biomarker testing related right now, when we're not doing it in-house, just inherently seems like, wait, now that can't be right. But when he was talking about readiness and readiness for implementation, we do have some advantages in that. As I mentioned, it is one healthcare authority right now in the province. So, in terms of these inequities across different jurisdictions and within different jurisdictions, we are definitely making efforts now to have that equity across our province with standardized reflexive testing documents and standardized processes. One of the things he was looking at was having having an HTA type approach for biomarker assessment and which ones should be included. And we do have that program, right? We do have a provincial lab formulary advisory council. We have, a public facing website that keeps up to date what tests we're doing, and with application forms for requesting new tests. So I think a lot of the things that he was looking for in terms of readiness for doing this, we do have. So, it's surprising. I think it's also a goal to, okay, we have to live up to this now and actually make good on the infrastructure we have in place and start doing this in-house and maintain our high score.
Thank you. So how, I know you're also involved in sort of these national conversations. How do we take Newfoundland's success and translate to the national level?
Well, I think interestingly, we're, our, committee to approach and assess new biomarkers is something that we're looking at the national level, of having sort of that national framework of assessing biomarkers for clinical utility, to have them sort of, so I think we're learning from each other as we go. This process has been in place in Newfoundland now for 2 or 3 years, but I know other provinces have similar networks in place and structures in place that have been existing for just as long, if not longer. I think there's definitely room for improvement in our system. And I think a big missing piece right now is having the approvals by the lab formulary coupled with funding, and having funds available to put into action immediately new tests when they're approved, and to having the biomarker assessments sort of done at the same time as the drugs are coming through, because right now it's still a little bit fragmented. So I think the national level, making this more widespread and having that national framework with the support will help us to reach those goals as well, and have the funding hopefully available as well. So I think we're kind of helping each other as we go, all learning together.
Great, thank you. Dr. Itani, I guess a question for you. So with this national framework being developed, how do you think this would potentially help or even harm you in terms of your efforts in your jurisdiction?
In New Brunswick, so first of all, I just want to say that this national drive does not restrict the type or the method of the test that we are going to implement in the lab. It will present a guideline that supports. It will say, okay, this biomarker, it's a deletion or a point mutation, or, and it needs to be tested with this drug as a companion, where not necessarily as a companion diagnostic assay, it could be an LDT. So the one thing, the nice thing that's happening with this initiative.
Dr. Itani?
Yes.
I'm just going to interrupt you for a moment. I think we're experiencing some technical. No? Okay. My apologies. Continue on.
No problem. So the good thing about this initiative is that it is not being restrictive. It hopefully will provide support to move in the direction, and then leave some input of the lab director or the local medical authority to shape the test such that it's available to the patients, but it also matches what's going on in the hospital, in the zone, in the province, and so on and so forth. So from that point of view, I don't think that's restrictive. That's actually going to be supportive, and you can use the funding that is available if it's coupled with the drug funds, which are, lab test funding compared to drug funds are basically minuscule, right? So in the lab budget, it's a huge amount, but in the pharmaceutical budget, that's it's nothing basically. It's probably the the GST or the HST of that, right? So I think it will help a lot, and it will facilitate our adoption of new assays and providing them to the patients. What I would like to say is that this is not the only thing that's needed, as was discussed before with all the participants. There's a widespread system level multi-deficiencies, right, at the level of human resources, not just MLAs, as you mentioned, all levels. Education also, there's a lot of new information that's coming from genetic testing, and you don't just need to educate the oncologist to read the report. You have to educate the pharmacist. They have to be, up to date with the recommendations. Comprehensive genomic profiling kind of unravels some unexpected, right, incidental findings in terms of pharmacogenomic variants that you have in your system, whether it's relevant to this type of cancer that you are dealing with now, or with some other drug, right, like warfarin, right? So this would be unexpected, and now the patient and the physician has to deal with that information, and the oncologist would turn to the pharmacist, and the pharmacist is not always aware, or it's not part of the education or the licensing process to go over these cutting edge findings, especially if they're incidental. So the system needs to be kind of supported in multi-different areas, right? So the other thing is the directing the patients from remote areas to centralized areas that has expertise, or developing centralized areas with expertise in remote areas, depending on how it works for that particular province. So just a lot of elements. This initiative is certainly a plus, but we need to do a lot more on multi-different facets to bring us up to par with what's going on in in the realm of treatment and targeted therapy. I just wanted to also say that the world is moving, well, at least the US is moving to not comprehensive genomic profiling. They're past that. They're starting to do whole exome sequencing on all of their tumors now. Like, this is the next thing. For us, that will not be feasible at this point, moving to whole exome sequencing for many, many reasons, right? Human resources, funding, like it's just not gonna work, but we're trying to get to the closest to that possible. And so yeah, hopefully we can think about the future while we are trying to find solutions to the variability that we have, to the access that we have, to the workforce that we need to. So just think that, you know, comprehensive genomic profiling is not end of the line. You know, there's something coming bigger, and we actually need to plan for that, because by the time it takes us a few years to come up with, you know, to come to the par with comprehensive genomic profiling, it's just past that. So we need to start planning for the bigger things so that we can make a leap, right? Once we get approvals, once we get our resources in place, then we can make the leap and catch up to the bigger thing, rather than just, you know, have to fight another battle now from, you know, the step of CGP to the step of whole exome, or to the step of whole genome. So just thinking outside the box and thinking more into the future. 5-year time is not, that's used to be the, you know, the time period you think about things and you plan for things, but currently you need to think what will happen in 10 years. I'm planning for 5 years, but can I take the opportunity and make efficiencies? Actually, if you think further down the line, you can plan better and you can implement better infrastructure that will make better efficiencies in the future. Instead of replicating your work, you've already allowed for that. One example I can give is when drugs are being approved in the province, and I get an email, you know, from the pharmaceuticals that are, you know, sorry, from the Department of Health. They are trying to see if we have the biomarker there. Since we've implemented the comprehensive genomic profiling, my answer has always been yes. That's, well, not always, but, you know, the vast majority of biomarkers has always, yes, this is available in New Brunswick, and I don't even have to do anything about it. It's already in my panel. I'm already reporting it if it's there or not. So basically, that saved us a whole lot of work from doing, you know, these stepwise, okay, now there's a new biomarker coming, right? So that gave us an efficiency, right? Going for that leap, although it worked well for our lab, but it also gave us efficiency to the province in implementing, you know, or accepting drugs that are being used in the province, because the biomarkers is already available. You don't have to wait another 6 months to a year to find funding, then validate the test, then have it available. In the meantime, you're sending all those tests out of province. So it's like double or triple the cost. But just because we were able to, you know, implement that earlier, we are saving a lot of time, we're saving a lot of duplication in work and a lot of money to the province.
So, you know, perhaps a national framework might sort of allow you to share those steps with others. Let me move on to Dr. Karamchandani. So we know that in Quebec, Quebec tends to work with Canada, but also do things independently. How do you see this national framework working with processes that exist already in Quebec?
Another very good question, Dr. Banerji, and it is something that emerged from our recent discussion as a challenge. And I've already mentioned the different approval processes between different provinces and some of the companion work between the CDA and individual provincial funding decisions. And that overlap is even more pronounced here in Quebec, where some of the work of the CDA is duplicated by our funder, which is INES. There we come into a very interesting challenge, which is the human element of this. This is a psychological problem. The idea that what is true is, according to the Constitution, healthcare is a provincial responsibility. Every province is entitled to take control of this area and say, we're going to do this the way that makes sense for our population in our province. What I believe we agree on here is that from the patient perspective, and as Canadians, we all look forward to a national framework to improve the delivery of care to all Canadians, to prevent some of the variability that Robby talked about within her family, within a province. So I think as patients, we can rally behind the need for a national framework. I think that will mean working with our provincial governments to help them understand that we support their efforts to be part of this national framework as part of their responsibility to do what's best for the citizens of their province. But that will very much require patients, voters, and healthcare professionals to work with people at the provincial level to work towards a common national solution, as opposed to the more traditional approach, which is it's 10 different healthcare systems and 10 different approaches.
Great, thank you. And then move to Dr. Laskin and sort of get your final word on this question, which is how do you see the national framework fitting, and how does it potentially help or harm you in terms of what's going on in BC?
Well, I mean, there's just so many talking points. This is a great panel. I think we could go on all day. It's hard not to get caught up in some of the things that my colleagues have brought up. I mean, I think a common element that what we're discussing is that the technology that we have available is so far ahead of what we're actually doing in clinic. And I often feel like in clinic, I'm kind of using stone tools, but, my colleagues, in the lab, you've got basically like an iPhone 15 or whatever. And I'm picking up the phone and I'm bashing it on the head, something, like technology is rapidly outpacing us, and we have to see that as something good. And it's hard, as Dr. Hyde said, what are our responsibilities for keeping up with all of this data and educating ourselves, and the burden of that responsibility can, especially for germline changes. And I do think we kind of have to separate a little bit about what germline results might mean and what somatic results. So, what is any hereditary possibilities in families, and that data can change over time. And then also what you see in some individuals' tumor. I mean, huge topics here. And I think it comes, a lot with education and the support of our colleagues and a closer integration of lab and genomics expertise into the clinic. I can't talk enough about the usefulness of molecular tumor boards and how important it is. We've been incredibly lucky to have a really excellent multidisciplinary tumor board and we educate each other. And I think that has helped a lot. And research obviously pushes all of us. I think, in oncology, no matter what your specialty in oncology might be, pathology or surgery or whatever, we're used to a fast pace of change, and it tends to attract people who want to learn more and need to learn what to absorb rapidly and what you can kind of ignore and move on with. So I'm hoping that we've got a collection of people across the country that are ready to embrace that in the midst of all of our other funding and staffing shortages. So what does this mean on a national level? I think Jason summarized it really nicely, to say healthcare is a provincial issue, and also we need some national standards to meet. And there needs to be flexibility, because each province is going to do it differently. Each jurisdiction is going to do it differently, and that's okay, as long as there is some agreement to do more than just the bare minimum. And it is going to take some time to get, something equitable And there's still going to be frustrations and disappointments and time pressure, as Robby so eloquently shared with us, incredibly frustrating on a patient level. But I think we have to support a national framework. At the very minimum, it brings people together with common experiences. And I think that we as Canadians have a lot to learn from each other and to share. And I think that bringing more and more people together, coast to coast, in these kinds of discussions can be really valuable. We don't all have to reinvent everything locally. We can learn from each other. That would be my take.
Thank you. There's an interesting audience question here, which I think actually it would fit best with it directed to you. So the question is it possible to have consistent access to CGP testing while at the same time also having innovative access to newer technologies, newer approaches? How do you balance these seemingly contrasting points?
Well, I'll try to answer that, but maybe others want to chime in as well. I mean, I think that, yes, it's possible to have some basic, it's like, think about a panel. It's very possible to have access to a panel, at least conceptually. Maybe people don't have tissue, so they need a liquid biopsy. Like, may not be an identical panel, but I think it's very possible for us to create frameworks by which people have access to some basic testing. Now, how that testing is going to be used for specific clinical care is going to depend on a specific situation. So I don't think it's reasonable to expect that we're going to be able to match every finding to every drug immediately without any kind of data. Like that we still need data to support some of that. But I think that the testing can expand. And then at the same time, in terms of more comprehensive or exploratory technologies, that's the research domain. And I think that we can only get better through research. And we have an incredible research opportunity within Canada in terms of genomics, with Terry Fox Marathon of Hope program, for example, which is really establishing this network of Canadian cooperation, bringing people together and pushing the edges of what we can do, and challenging us from an educational opportunity as well. So I feel like you have to do two things at once. You have to do some basic fundamental standards, and those are going to shift. And then you also have to push the envelope. And we are in an amazing position in Canada. We have incredible resources in terms of intelligence and technology to really change not just the standard for Canadians, but I think globally.
Very well said, as always. So a couple more audience questions. I'm just going to open it up to whoever wants to jump in. So the first question is getting back to the human resource challenges that were highlighted by several panelists today. And so, there's need to attract and train everyone from molecular pathologists to others who specialize in computational molecular pathology, and even training more MLTs. So open to anyone who'd like to take this on. What do you think we can do to address some of these human resource challenges?
So I don't mind taking a first stab at this, because this, as I mentioned, is one of the most serious challenges confronting lab medicine in the country. So we did a bit of a landscape analysis and looked at, first of all, is this problem Canadian or is it a global problem? And I'm happy to say this is not a Canadian problem. The same shortages exist in the United States, despite a very different system for healthcare funding. So there's more flexibility on salaries, there's more flexibility on how people are recruited, and yet the same challenge is across the country, across different states. It's also true in the UK and other developed nations. So good, this is not a Canadian problem. Bad news, it's a serious problem. It's a global problem. What do you do? So we've already identified some excellent practices and innovations in other countries, and it starts earlier than you'd think. So I think I interact with medical students, and that's how I'm going to get someone into lab medicine. That's where the point of first contact might be. But it turns out you have to go all the way back into the early high school years and capture the imagination of young people to even let them know that there is a job called a cytotechnologist. There's a job, a cytopathologist who reviews smears before it goes off to the pathologist. These positions are invisible. So it's incumbent on us to even inform the young generation that this is a possibility for a financially viable and highly rewarding career. And so we're starting our process of emulating these best behaviors to outreach at the level of high school students. And I think we might have to go even earlier than that to capture the minds of Canadians.
Thank you. That was a fantastic response. So I think just in the sake of time, we have one last question, which again, it's open to the panel. But yesterday at the Conference Board of Canada, it was some data was presented about the cost effectiveness of CGP and some of the challenges around funding in a resource limited environment. But in the presentation was also the point that access to testing like CGP has about $180 million positive impact to the economy as a whole through some of the benefits that the conference board identified. Any thoughts from one of the panelists on this economic impact? Maybe I'll ask Robby first.
I was actually going to jump in, so that worked out. That's not surprising. I mean, you also have, from the patient perspective, like if you think about what that economic waste or economic cost and savings is, it's a lot of trial and error on treatments for patients that are a waste of time or don't work or cause a lot of side effects. And so I say this a lot, and this comes from my pre-cancer background, but there's a reason we have health technology assessments and we look at the cost of different things and different tools. But now you have like that change for me is that perspective, right? So what does savings actually mean? Savings actually means a benefit to the patients, either in saving their lives or minimizing harm to them from a lot of therapies. And I'm not going to dive into it, but I've had some issues with my adjunct therapy in the last 3 or 4 months. And certainly, like if there was a targeted test for that, that would save a lot of trial and error for lots of women going through that. And so the more information that we have, especially from the patient perspective, the more that either current or future treatments can be accurately targeted. And I'll also add that savings are often looked at in election cycles and not in the longer term. And so the more data that we can have and the more we can prove that investing in these innovations upfront lead to long-term savings and long-term benefits to patients, the better the system will ultimately be.
Thank you. I guess we're getting close to the end of our hour. I guess last question to the panel: is there anything that you feel remains unsaid about the role of the laboratory and some of the opportunities and challenges we're facing?
If I may leave us on a positive note, when we introduced immunotherapy, there was variation of up to 18 months across the country in the adoption of a very simple immunohistochemical test required to administer this precision therapy. The story is evolving. So with Cloudin-1, at least there's still some inequity. So only 7 or 8 of the provinces were represented on the first map of people that'll be ready to go the day this is approved. But in the last month, those provinces have been represented and joined this validation network. So for that new therapy, we're going to be ready for it the day it's approved across the country. So I'm happy to say we're learning. It relies on individual champions, but we're making progress.
Thank you for that. And thank you, everyone for sort of your important contributions and the discussion today. I guess I don't see any other questions, so perhaps I'll hand it back to Cassandra and Philomena.
Thank you so much. Wow, what a great discussion that was. In the last presentation, I spoke about the importance and the impact of the champions who are driving improvements in Canada's biomarker landscape. And you all are most certainly some of the experts leading these improvements in Canada. So thank you so much for the work that you do each and every day. Thank you for being a part of this panel discussion as well. It was very, very interesting. So again, just thanks for being here and contributing. And now we will head into our first health break of the day. So I invite you to take this opportunity to grab maybe a quick bite to eat, take a movement break, and you can watch the educational videos that will be playing throughout. We are back with our clinician roundtable discussion at 12:15 Eastern Time and look forward to seeing you then. Thank you.